right, good afternoon, everybody. My name is Kevin Corbett. I'm the CEO of the Healthcare Authority. I'm also the Secretary of Health and Mental Health here in the state of Oklahoma. Really appreciate you all being here. Sorry for the slight delay, but also welcome to our folks that are online with us today. This is our chance to share with you a real significant transformation that's going on in our Medicaid program. We are really moving the needle with regards to what we're trying to accomplish for our population and our members with regards to health outcomes. And that is really making a transformation to a managed care model for our members today, as well as our expansion members in the future. This meeting is to really give you an opportunity to hear from us, and we hear from you with regards to what that means to the provider community in terms of how that will work for you. I've got my colleagues here from the Healthcare Authority. I'll have them introduce themselves, and they're here to answer the questions that might be on your mind, as well as give you some information that you hopefully will find value in with regards to what this really means for you, the kind of the tactical things, the operational protocols that we'll have in place. I hope you took some opportunity with this slight delay to maybe meet our health plan partners as well. Part of our transformation with regards to our managed care model is to partner with a set of health plans to help us achieve our objective. And our objective is really simple. It's about really improving health outcomes in the state of Oklahoma. I think you all probably have heard many times over that we need a lot of improvement in health outcomes. We're rated 46 in the country. A lot of attempts at that, lots of great improvements have occurred over time, but we simply find ourselves with the need to do something more and more boldly. So that is what we're focused here to do. So we want to make sure that we have the opportunity to answer all your questions today. If we don't get them today, we'll certainly respond to those through our normal communication protocols. But let me first do this. Let me thank the Kiamichi Technology Center for the hosting of today. This hospitality is greatly appreciated. Fantastic facility here. But I also want to introduce our health plans that are our partners, accountable to us because we still own the responsibility for the Medicaid program in the state of Oklahoma. And that is Blue Cross and Blue Shield, Oklahoma Complete Health, Humana Healthy Horizons, and United Healthcare on the health side. We also have 3 dental plans, DentaQuest, Liberty Dental, as well as MCNA. They're all represented here today. Hopefully you have the opportunity to visit with them. But we want to give you an idea of what we're really trying to do here with something that we really think is transformational. That's our SoonerSelect program. The partners that we've identified and contracted with are part of our success in that. But I also want to introduce my team here who will answer the questions that might be available to you, of interest of you, and share some information. So Mel, would you go through and just introduce yourself and your role and to pass down the mic to everybody?
Sure. I don't even know what time it is. Good afternoon. I'm Melody Anthony, and I'm the State Medicaid Director and the Chief Operating Officer at the Healthcare Authority, and I've been there for a little over 15 years.
Hi, Trey Lorraines, Deputy State Medicaid Director and Managed Care Implementation Lead.
Hey there, Aaron Morris. I'm the Chief Financial Officer for the Healthcare Authority.
Welcome, I'm Karen Luth, the Dental Director.
Terry Cothran, the Pharmacy Director.
Good afternoon, I'm Nathan Valentine, the Chief Quality Officer.
Thank you all. Let me start with some basics here as we talk about managed care and managed care organizations. It's really health plans, as we talked about. It's kind of an insurance company who's responsible for coordinating health services for our Medicaid members. And they really focus on whole person care in a healthy home model to support our members in a coordination of care, whether it's medical, dental, or behavioral health, as well as addressing social determinants of health that we know are real critical to achieving our outcomes that we so desire. I know this is not a new concept for many of you, certainly not a new concept around the nation. 40 other states have taken this approach. We've looked at each one of those states as well as our own history in this particular move and really wanted to take the best of what each had achieved, at the same time avoiding any challenges or problems that might have been incurred in the past, either by ourselves or by other health plans. Let me talk about the SoonerSelect program, what that represents. That is our ability to enroll a number of our members today into these health plans, very much similar to what you might experience as a member of an employer plan or another plan like that. This is the same kind of concept. We'll have about 800,000 members that we currently have in our membership that will move to a health plan. That's largely our children, pregnant women, caretakers, as well as our expansion population. And again, the majority of this is going to be children. With expansion, we'll have about 1.2 million in total membership in the Medicaid program in the state of Oklahoma. For those that might be interested, that's close to 30% of our population in Oklahoma. So we have a significant role with regards to this population and our role in serving them. Our populations that will not be part of the program are age blind to disabled. That's a small number, but a very significant and fragile group. That's a group that we are contemplating the possibility of them moving to a health plan participation in the future, but currently not now. And obviously our tribal members, they certainly have the ability to be part of our process, but they have no obligation to participate. So they have the opportunity to opt in, as we call it. You might be interested in what's the time frame on this. Here we are in early April. We will anticipate a launch of this program in October 1. If you're keeping track of dates, we also have a very significant date coming up in advance of this, and that's expansion. Expansion will occur 7/1. This plan will launch 10/1, in which our expansion members will be a part of this enrollment process. Let me make a comment on expansion real quick. We certainly have been working a dual path with regards to this transformation initiative, but it's also having the opportunity to serve about 200,000 new members, which is going to make up the expansion population. There's a lot of work that's gone into that. We'll be announcing certain enrollment processes and communication for the general public, but what we'd like to make sure that we have the opportunity to do is enlist the provider community to be a part of this, both in terms of serving these members, if you don't currently already, but also be an assistance to enrollment and things that you do for our current population in terms of helping them become part of the Medicaid program. We'd certainly like that to be an opportunity for this expansion process as well. I joined the Healthcare Authority about 18 months ago, and I did that on the basis of the governor sharing with me his desire to be a top 10 state. And certainly his support on that and the support of this is unwavering. He certainly has a drive to be a top 10 state. Health outcomes is clearly part of that process. If you ever come to the Healthcare Authority and walk into our boardroom, you'll see two signs. One is our vision statement, one's our mission statement. And I think the vision statement tells it all. We really want Oklahomans to be healthy and have access to quality healthcare, regardless of the ability to pay. That's our contribution to this population. We certainly honor that, and we think this is the way for us to demonstrate our commitment to that. So we also know how valuable our provider community is. It's very clear, and I say it many times, is that we do not deliver healthcare at the Healthcare Authority. We facilitate it. So do our health plans. The provider community is what's vital to delivering healthcare. We're very blessed to have close to 70,000 providers in the state right now that serve our Medicaid population. That's a significant contribution on your part. We know that there are shortages in certain parts of the state. That's been something that we've been dealing with as far as access. But we certainly want you to continue to be a provider for our population today and in the future and work with us to achieve the outcomes that we're looking at. This whole process began for us in terms of transformation many, many months ago. When we started the undertaking of really doing the diligence of how we're going to really honor our vision and our commitment to that vision. And we sought input on all of these matters. We actually sent out a request for information to the provider community, our tribal partners and others to tell us what was important in designing a program like this. We received close to about 100 responses back, many of them many pages long. All of them were taken into consideration, many of them implemented in what I'll call our commitment to the program, which is our contract with our health plans in terms of what we're going to require and what's going to be the expectation of delivery. All of that has been communicated to the plans, everything has been communicated to our board. And today, all my colleagues will share with you some of those items that are part of the contractual process, but I more importantly call them our commitment to each other. Because we do look at everybody as a partner, whether it's us, health plans, as well as our provider community. I think we're all in this together. So let me start and have Mel or Traylor talk about the kind of key concepts that we've developed with regards to what might be of interest to you. Some of these more strategic, some of these more tactical, and then we'll certainly open it up for questions. I'll turn it over to Melissa Ritchie, who's going to be our communications chief, to kind of facilitate the questions. I'm going to join the panel to participate in the Q&A. So Mel, would you take the opportunity to kind of share some provisions and items of interest the team.
It's red, it's not green. I could probably just talk. But, thank you. Thank you. I want to say I'm really happy to be here, and also want to say I've seen some friends in the audience. So it's nice to see some friendly faces. So when you sit down and try and decide as a healthcare delivery system how to have the biggest impact on the providers, which are our partners, but even a bigger impact on the members that we serve, the first thing we did is we sat down and we looked at our current program today. And then we got into a room and started brainstorming about how do we keep what we have today and make sure that anyone who contracts with us understands what we have today so they can mirror what we do today, but they're also able to do more than we're able to do today. Because if you're a Medicaid delivery system in any state, the federal government said the only thing that you're allowed to pay for is medically necessary services. That leaves a lot of unmet needs on the table. And so the federal government came up with a way to enhance wraparound services that a Medicaid member or family would need. And they were able to do that by giving Medicaid managed care plans flexibility. So we made sure that our partners, when they responded to our request for information, looked at our plan today, understood what our requirements were of them, and made sure that we put all those guardrails in that 5,000-page document, it seemed like. It was hard. It was big, very big. In fact, they complained about how big it was. It was the largest RFP they'd ever seen. So kudos to the team for doing the work. So we also put in a lot of specialty things, like we pay every week. We expect them to pay at least every 14 days. We track our denial rates. We'll track their denial rates. We do prior authorizations. They'll do prior authorizations. You know, they do care coordination. So do we. I mean, we actually sat down and made sure that the requirements in our RFP was exactly what our populations were used to, either from a provider or a member perspective, and then gave them the opportunity to tell us things they could do that we can't federally do today. So some of those things I'm going to let Traylor talk about. We put some little nuances in it that I think will add some additional value to the program that we have today.
Thanks, Mel. So I'll start by just saying, I know that a lot of folks are comparing possibly the way we're implementing today, the way we implemented in the 90s, early 2000s, if we've all kind of been around the system for that length of time. I will say there's a lot of stuff that we learned from our experiment with managed care in the 90s, one of which was it wasn't statewide back then. So we saw a lot of members, if they would move outside of a metro area, their care would go back to the healthcare authority. If they lived in a metro area, it was with the managed care plan. And there was a lot of unmet need in our rural areas at the time. There was a lot of discrepancies in payment methodologies and reimbursement rates for providers, which led to a sharp decline in provider participation in the 90s, early 2000s. And that's why at the time we ended that program and went back to the Healthcare Authority Direct Administration and did things like raise rates to 100% of Medicare, pay on a weekly basis, because we knew that's what it would take to really get our provider network where it needs to be. So as we went through that process, and as Mel said, developing this RFP this time, we remembered those things and we created a statewide solution where all of our partners in the room will provide services and coordination statewide. So no matter where you move, if you're in Buffalo one day and you move to Ardmore the next, you will maintain your plan, you'll maintain your care coordinator, they'll help transition your care. And that's true for all the families and members on Sooner Care, and that will transition to this model. One thing that I'm personally excited about as we transition to this model is we do have one of our partners, Oklahoma Complete Health, is actually the single vendor to provide care delivery and care coordination for our specialty children's plan, which is designed specifically for kids in the custody of the state through child welfare, juvenile affairs. So as a lot of you know, if you work with that population, you know there currently is no care coordination model for those kiddos because they're exempted or accepted from our patient-centered medical home model. So we're super excited about bringing this as a resource to our already under-resourced child welfare staff that have to not only coordinate the child's child welfare case, work with foster and adoptive families and bio parents, but also have to become experts in mental health and specialty care and getting those resources. Now they'll have that opportunity through Oklahoma Complete Health Care Coordination System to really rely on them to help support them in identifying, through health risk screening for the kiddos, as well as identifying specialty care, mental health care, and finding those providers and really relieving that burden from those child welfare workers. But the same model will be for all of our plans, for all of our populations. The children's one is just more specifically targeted towards the population. As Mel said, and Kevin alluded to too, this is not one of those situations where we're simply handing the keys away to the castle. There's a lot of implementation and oversight and monitoring to be done by the Medicaid agency throughout this project. If we showed you our reporting requirements, you'd probably be in all of the monthly, weekly, annually, semi-annually reporting that each of these plans have to do so that we make sure they're treating the providers well and getting the services to members, as Mel mentioned. Prior authorization times, we know that's a big deal. We have fairly quick turnarounds for PAs now, so we're requiring the same of our plans. If we see in those weekly and monthly reports that timelines are slipping off target, we have penalties for that. Same thing for reimbursement rates. We recognize that we've done well in inching our reimbursement rates up towards that of Medicare as a state. We recognize that traditionally behavioral health services, for example, have been long underfunded in the state, and we didn't want them to dip below that. So we did certain reimbursement floors for our behavioral health providers, for example. So they cannot actually reimburse less than we do today for behavioral health services. And we know there's concerns with, contracting with providers, and what if they don't pay me enough, and what if we're not able to continue seeing our clients. What I will say is there are very stringent requirements for what we're calling adequate networks that the plans have to meet. And it's actually a little more strict than the healthcare authority is held to. We look at that through time and distance standards. So we say, okay, we have to have PCPs within, I believe, 25 miles of a member, or 15 minutes, I believe. I have to refer to the contract. And so they have to show us weekly what their networks look like, what their geo mapping looks like, to show that we have enough providers in a certain area to meet those time and distance standards. So chances are they're going to be actually recruiting more providers than we currently have in our system today, not decreasing the amount of providers. To get to that adequate network, they're going to have to pay you an adequate rate. You can't, and I'm hearing things from the provider community about, cutting rates by 20 to 40%. What I would say is there's no way our plans can create an adequate network if they're paying less than we do today. And so we have all those safeguards in place moving forward so we can keep our eye on it.
Okay. So with that, I'll have Melissa come facilitate. I'll join the panel, and we're open for questions both here in the room as well as online. I think we have some monitors back home, I'll call it, that's watching the online questions.
We do, yes. So we will go ahead and start with our group here in person as our online monitors work to answer those questions online. And then if we do have some virtual questions that we want to bring to the panel, we will do that intermediately. So is there anybody in person who would like to start with the questions?
Yes, I'm Bob Carter. I'm the administrator at the local hospital. And I've actually got 3 questions. I can tie them all together if y'all want to do that, but I could ask them individually. House Bill 1091 passed the House a couple of weeks ago by an overwhelming majority, which would put some pretty stringent restrictions upon these healthcare plans. When it went over to the Senate, one of Governor Stitt's allies, Senator Kim David, has buried it in committee and is not going to let it come out to the floor. When you couple the House's vote, and that's the people's House of this state, when you couple that vote, along with the fact that you have every medical association in the state of Oklahoma adamantly opposing this program, how do you justify moving forward?
I guess I would answer that question in, we have a commitment to improving health outcomes. And we've been where we are today for more years than I think we would care to admit. And it's been our commitment at the Healthcare Authority to do our part to achieve a better improvement in health outcomes. We do a fantastic job at the Healthcare Authority in facilitating access to care and payment for care. But the level of coordination and management of helping individuals become more healthy is something that we have not been able to do to the extent that we need to do. And this is our attempt to do that. We think having the opportunity to use those that have built expertise, scale, capabilities throughout the country to be part of our process to help us achieve our goal. Again, as Traylor said, this is not our attempt to outsource or to transfer our responsibility. It's simply to find a solution for something that we are in dire need to do.
So this has been a hot topic, for several months now. And over the last few months, I've talked to healthcare executives in several of the 40 states that already have the program in place. I have talked to executives of the companies that are represented here today. And to a person, I have not found one person who can tell me that this would be good for Oklahoma. And I want you to understand, I spent many countless sleepless nights because of this mess. I'd just like to know that one of you guys is not sleeping either. You know, it's, this is, goes absolutely against what the will of the people and the will of the medical community. This is warning for our people. I've been in healthcare 27 years. I was here whenever we had managed care back in the 90s, okay? And I deal with these particular insurance companies on a daily basis. I know what's fixing to happen, unfortunately. And again, I just like to know that somebody's not sleeping besides me.
Well, I'll tell you, I have restless nights because of what we've charged to do, which is to transform our role into an oversight role to achieve a greater commitment than what we've been able to achieve today. And I think everyone would say that they are having those levels of anxiety as well, because we have a daunting task in terms of the Healthcare Authority. Our role here is to make this operationally successful. And that's what we're striving for. And that's why we put in the contract so many requirements to make this program successful, where maybe other states weren't successful. We've had the opportunity to talk with many states. I wish there was a universal answer that says this works everywhere in all regards. That is not the case. Every state has had its challenges. Every state has had their successes in different ways. We've taken the best of what they've achieved. We've tried to ignore or eliminate any possibility of those things that could going wrong, and we put in mechanisms to let us know if they are. But we're kind of committed to doing our part on this. And quite frankly, we look at our role is a member first role, is what's important and what's in the best interest of 1.2 million of our citizens. And that's our kind of commitment to that. We recognize that we've got a lot to do, and a lot of folks need to be with us to do that. That's the partner, that's the provider community, that's our health plans, that's our legislature. And we're working to make this a success because that's been our direction, is to make it a success.
Can I add?
Sure.
Can I lean in a little more to your statements and ask to unpack a little more of the actual concerns that maybe we could address in more specificity?
Absolutely. I don't have a clue today what this is going to cost us in our local hospital and added personnel to fight the day-to-day denials, the peer review, the peer-to-peer calls that are going to have to take the doctor out of the room, so on and so forth. We don't have a clue. You say that it's going to pay at least what we're getting paid today, but we don't know that. I'll just make a statement here. I think if you guys had these meetings, the statewide, going around the state when this all started, you might have got more buy-in on this, but this has all kind of been done in secrecy. We don't have a great lot of information about what you're going to do, how it's going to be paid, anything else. I have the utmost respect for Aaron Morrissey, and I've been friends for a long time, okay? But we totally differ on this. But it's like I told him, this is business. We'll be friends when this is all over with. But ultimately, at the end of the day, I think that's the biggest hiccup that happened among the healthcare authority and the governor is the fact that you didn't get buy-in on the front end. Instead, we're here to tell you what we've done to you, so to speak. And we still don't know what you're going to do.
Well, we're in the process of doing that right now in terms of implementation. That's the whole point of these town halls, is to engage with you in terms of what that means. Make sure that you understand the level of diligence that we went through to develop the requirements. Hopefully put you at ease on some things that you may have not been at ease because you didn't know. As Melody mentioned, it's a very large contract. It's got lots of provisions, lots of pages. We're simplifying that in terms of what we think would be important for you to know, but certainly we're not going to make that judgment call. It's about what you need to know. And hopefully we'll hear from you to know what that is, and we'll provide you the details that you desire, because our intent is to be totally transparent on this. I mean, again, this is a partnership across the state, and there's a lot of partners involved, and we need them to be involved.
Hi, I'm Rick Wagner. I am the CFO or interim CFO for 6 different hospital facilities in eastern Oklahoma. And I can tell you that at this point in time, none of those 6 plan on signing any contracts. So you'll have a hard time meeting your geographic requirements unless you make some changes. One of those changes I noticed just on your slides that you had up here earlier, it said on your slide that you were requiring the provide the new insurance companies to pay more than the current Medicaid rate. Well, if you look at the contracts I've been sent, they all say current Medicaid rates. They don't say more. And I know from doing managed care for Medicare that it's going to be less. I tell you that I average 4 to 5% less from a managed Medicare program than I do from Medicare. That's due to denials, refusal to treat patients. I'll get pre-approval for services, and then they're denied because of some technicality. It's really an abomination of the program. The other thing I want to point out is that there's a current SHOP program in the state. That SHOP program is designed, I've done this for 40 years. So that SHOP program was designed to actually tilt the scales of the money towards the rural providers, and which is sorely needed in this state. We underfund all rural healthcare in this state. Everyone, it seems like in Oklahoma City, would rather just see everybody drive to the urban areas and get their care, and they could care less if they die early because they live in a rural part of the state. That SHOP program then is going to change under managed Medicaid, and it's going to go to a volume-based payment. Guess where the volume's at? In the urban centers. So you're going to change the SHOP program to be tilted towards the rural area, to be tilted towards the urban area. That SHOP program is the only reason many of these hospitals are still open. So you're going to wind up closing hospitals, having fewer providers rather than more providers. So I'd like to know what you stand to do about that. And the other question I got is that why would you contract with the providers, that the insurance companies that you have contracted with, and bring them into the state? The Centene provider in itself, if you just Google the Centene provider, you find it's the most sued provider in the United States. They deny care, they ration care, they've had infants die at home because they wouldn't treat them. And I think I think you've not done your due diligence on who you bring to the state. The other thing you've done is you've said that you're going to cut Medicaid utilization by 40%. If you cut Medicaid utilization by 40%, our hospitals are dependent on a 340B program. That 340B program is dependent upon the Medicaid utilization. If you cut that utilization by 40%, we'll lose our 340B programs. And those 340B programs fund cancer treatment in rural Oklahoma. There again, you just told all the cancer patients in rural Oklahoma, you don't need to get your treatment in rural Oklahoma. Go to the urban areas where everybody should get better care because they must be better. They're in the urban area. So I think you have done a disservice to every rural provider in this state by going to this managed care program. And I can tell you that you're going to have a difficult time having a patient seen in eastern Oklahoma.
Well, I appreciate the viewpoints and the questions. Let me first address your first one when you talk about your experience with Medicare and employer plans. I look at our role in the Medicaid program different than maybe others that sponsor those plans. we have a commitment and a responsibility to oversee and be accountable for our members. And that's 1.2 million in the state. I don't know any Medicare program or employer program that has that level of responsibility and accountability. So in terms of things that can go wrong, like denial rates and things of that nature, that's our role. We're not going to let that happen. That's why we have the guardrails in place. You'll have to judge us on the basis of how we perform, but that's our role, that's our accountability, that's our commitment to the state. Otherwise, what's our purpose, if you will? With regards to SHOP, I'll have Aaron talk about that, but that was a key component of our diligence, is to ensure that our supplemental payment program in the state, which SHOP is the largest piece of, but just so you know, our program today, the Medicaid program today, is about a $6.5 billion program. Majority of that's paid by the feds, but obviously there's a large portion that the state taxpayers pay. It's going to go up to about $8 billion with expansion. And so the supplemental payment portion of that is about $1 billion. We certainly weren't going to put $1 billion at risk, particularly in terms of what it means to rural hospitals. So we've been working very diligently to preserve that program, and we're announcing later today or tomorrow that we have approval by CMS to preserve that program. Yes, it's a little different, and Aaron can go through the details of that, but virtually the same. So that is going to stay intact. We recognize the 340B, which is the drug rebate program, for those that might not know, for hospitals. It is not a Medicaid program, just so everybody understands that. We have our own drug rebate program. We created our own contract where we own the formulary. Dr. Cawthon could talk about this, as well as the rebate program. But the 340B rests with outside the Medicaid program. What's interesting about it is the eligibility, as you know, is tied to Medicaid census data, which I understand this year that's been under siege because of the lack of utilization because of the pandemic. And there's an eligibility requirement that you have to meet certain levels to be a participant in that. We understand that. We're obviously having conversations about that and trying to understand it more, but it's not a program that the Medicaid organization has facilitated or participated in. So, Aaron, you want to talk about supplemental payments just so she has the opportunity to understand current state?
Sure, appreciate the question.
You kill the 340B program because it's not yours.
I'm not saying that. I'm saying
That's what you just said.
No, I'm saying it's not a program that we administer. We recognize the impact it has on hospitals, and we're trying to understand more, because we recognize that this pandemic period of time has had an impact on that as well.
So I absolutely agree. SHOP is vital, not only to our rural hospitals, but just hospitals statewide. And we recognize that. And one of our priorities was to preserve that level of funding. And we have received approval to do so on both the SHOP side, which is our supplemental hospital payment program for most hospitals statewide.
Hold the microphone.
And our level 1 trauma program, which is a supplemental payment for level 1 trauma hospitals, which we only have one in the state currently. Rick, appreciate your feedback there. And we've done our due diligence and our best to kind of preserve the integrity, the structure, the level of funding as SHOP exists today. So yes, it's based on distribution, based on volume. It is based on volume today. We've preserved the pools. So critical access hospitals will have their own funding pool, and private hospitals will have their own funding pool, and non-state government-owned hospitals will have their own funding pool. So the pools are fixed. We use our same methodology as we have in the past to establish those pools, which is our upper payment limit calculation. We've trended that just as we would in the past. We've added assumptions for the expansion population and ramp up of utilization for those folks. And we've created this fixed pool. The distribution will, of course, be on utilization, that's a federal requirement. But we really feel like that's a distribution that is based on utilization today. Now, instead of looking back 1 year and projecting forward and making this a fixed payment, we're looking back 1 quarter. So we feel like that's a very similar structure with a slight change, a slight twist. It's more reactive and it's more real time. Now, if utilization across the board goes down, you still maintain your payment, your share of the pool, if you will. If utilization for your hospital is impacted adversely, or you have utilization increases, you will, move along that pool as you would today. So again, I would love to have a conversation with you to follow up, and we can get into a lot more detail on what this looks like. And that's the intent going forward, as we have a meeting with OHA planned tomorrow, and then we'll have a follow-up meeting with all hospitals, giving them the opportunity to kind of do a deep dive into SHOP and what it looks like and what it means to us going forward. So Rick, happy to have that conversation with you if you'd like.
Just wanted to comment real quick. Some of these concerns that we're talking about, my role is going to, in some ways, is going to be a check on those processes. So as the Chief Quality Officer, my job is to make sure that our teams are overseeing and facilitating quality improvements so we actually hit our health outcomes, our goals, to really improve the health of our members. And if we have providers getting pulled out of their exam rooms, if we have other barriers being put into place, then that's exactly the type of thing that our QI facilitators will be uncovering and we'll have to be addressing and fixing, because that's exactly the kind of barriers on the side of the care team that would get in the way of reaching our outcomes, of getting the screenings that need to be done, having the conversations that need to be done. Just like we'll be tackling the barriers on the side of the members in terms of social determinants of health, we also have to pay attention to that.
We're going to take a couple of our virtual questions now. Our first one is, will telemedicine continue to be available?
Yes. Yes, telehealth as currently used will be available, and we fully expect our partners to maybe enhance the use of telehealth. I've already heard some of the plans investing in technology that would be available to members, which is something that currently the Medicaid agency cannot reimburse for. It's like an iPad for a member, for example, and I've heard investments of that nature in order to better access.
And I'll just give you one sense of how important telemedicine has been with regard to telehealth has been through this pandemic. If you go back 12 months prior to the pandemic, the number of telehealth visits, and that's probably on the basis of what we compensated for or didn't, was slightly under about 10,000 visits for that annual period. This next annual period during the pandemic, we have certainly passed the 1 million mark and going up to about 1.5 million. So we see it as a vital part of the access to care. Sounds like the provider community, the member community are certainly in favor of that. So we'd like to see that actually continue and expand to the extent it can.
How will these changes affect the enhanced reimbursement for the teaching universities?
So again, that's another federal authority we seek to preserve. Our teaching, our teaching physicians, or our physicians affiliated with medical schools, publicly owned medical schools, receive an enhanced reimbursement. We wanted to preserve that. We've worked very closely with the medical schools to design a program that would preserve those funds. That one is very close, we believe, to approval, and it would just basically preserve the level of funding that we see today and the payment method. So as Traylor spoke about earlier, we did not dictate a floor on all rates, but we did pick out some that we thought were targeted, that were necessary, and our teaching physicians was one where we did establish a program that would maintain that floor.
This is a two-part question. Although a patient is assigned to a specific provider, can they see another member in the group?
Yes. You can. So when you enroll with one of our managed care plans, which the population will do in August, they will join that plan October 1 of 21, and they have 90 days to decide if they made the right decision. After that 90 days, they're locked in. I'll pick on Humana. So they're locked into Humana. But if Humana contracts with a medical clinic in Poteau, and there's multiple providers in that clinic, they can see anyone in that clinic as long as every provider is contracted with Humana, because the providers still have to be contracted with us, and they also have to be contracted with the plan, because the plan will be paying those claims. So they have to be in their system in order to be a compensable service. But yes, they will still have a little bit of flexibility. Now, will they be able to go across town and see a competitor? That's something that the plans will have to work out with us to make sure that we educate the provider community in the way that it will work in the new environment. But in the current environment, and I'm telling them this, I'm not telling you, you can go across town and see a competitor. So we'll work through all of that, but as long as they stay in the same clinic, they're good.
You answered the second part of that question, so good job. Do we have any in-person questions?
Real quick, I just wanted to expand on that just a little bit, because I think it's an important note, and as Mel was talking about it, it triggered something in my mind. So it's an important note when we're talking about supplemental payments and managed care. We also need to understand that to participate in those enhanced payments for physicians or hospitals, as we've been talking about, they have to be a enrolled provider with these companies. Federal regs don't allow us to pay those enhanced payments outside of that relationship. So it's an important note. Just to it must be a participating provider to receive those funds.
I think it's important for you to know, since you've commented.
I think it's important for you to know, since you commented, that we're supposed, as providers, supposed to be expected to get at least the current Medicaid rate or better, you said. I can tell you that I've got blank contracts from each of these providers now. The Blue Cross contract is actually less than your rate. They have sent it out, specifically said that they will pay less for lab services than the current Medicaid rate. And I think you need to address that with these providers that are over here, that they shouldn't be sending us contracts to even review that pay less than Medicaid.
We will look into that.
Like to piggyback off of Rick, is it?
Yeah.
Specifically, the other day, I had a member, I work for Rainbow Promise with the Advantage Waiver Program. I'm the PCA coordinator. I had a member call me the other day, all upset. They just got a letter from the Cancer Center in Tulsa, and as of June or July 1st, this cancer center is going to be closing due to this new Medicare expansion or whatever. So what would you say to that member if they brought that concern to you?
I would need more details, but I would start by saying Advantage members aren't affected by managed care. So Advantage members will continue to be and have their care administered through the Healthcare Authority, as well as our partners, Oklahoma Human Services. I'm not sure why the hospital or the cancer center would say that, because if anything, as we bring expansion on, which is separate from managed care July 1st, we're going to see more Medicaid reimbursement going into hospitals because a lot of our uninsured adults will now have access to care. So happy to follow up if you have a copy or get it later.
I do not have a copy of the letter. I did not read the letter. I'm just expressing the member's concern.
Sure. Then I would just say if you work with anyone that is on Sooner Care because of a disability or aged or on a waiver, let them know that managed care will not affect them at this point.
I'm Dennis Carter. I'm a local provider here. Based upon what I'm hearing to the left, it sounds as if some of your hospitals are not particularly interested in providing or accepting this particular contract. You have a mission statement that basically says you're supposed to provide some kind of access. I've read the mission statement about 3 times. I can pull it up on my phone. But it would be a violation of your mission statement if we didn't have these providers getting into the process. My other concern, if any of these hospitals close, where are these people going to go? If we have rural hospitals that close, south of here, east of here, west of here, actually not east, but west of here, where would those members go? To me, those state monies would be going automatically out of state. And we're not providing care. Currently in Latimer County, there is no hospital. EMS decides whether you make it somewhere if you survive your code. If you don't survive your code by EMS, you get to stay in the ambulance and go to the local funeral home. That is not a supposition, that is a fact. So where would the care be given? How's it going to be addressed?
So I would say that our providers, as a Sooner Care contact providers, have an obligation to see our patients, regardless of whether or not they're contracted with one of our partners at the tables across the way. They also have an obligation under EMTALA to provide care emergency-wise to our patients. If they choose not to contract with one of our partners, they would be considered an out-of-network provider and be reimbursed about 95% of what they would had they signed the contract. So we would still expect them to see patients. If not, that's a revenue loss to the hospital. It would just be less reimbursement than if they'd chosen to be in network.
I guess my statement was my question is, if these hospitals are not able to maintain, it sounds like there could be closures. Because some of these hospitals rely on a lot of these funds to maintain. If you have a 40% reduction in, the phraseology is utilization, and they cannot maintain and they close, the doctors are out of business. Where will those people go for care? How will they receive care?
And I'll pass to Aaron in a second, but what I would say is there's a lot of assumptions in the way we did rate making that assumes certain decreases based on improved quality of care. This is not an across the board 40% cut anywhere, which is why I'm trying to unpack the actual concerns that our hospital partners are having so that we can talk about them and talk through them and see what the actual details are around it. Because we don't expect huge dips in the way we reimburse providers or the income coming into their facilities.
Yeah, just to add quickly, a 40% reduction of services isn't across the board, and it's not a mandate. It's a assumption used for rate setting purposes, and it's a single assumption amongst a multitude of assumptions. So to be laser focused on one is difficult without understanding in greater detail. So this helps us set a rate that we will pay to our partners to manage the care of these members. If a member goes to a hospital, has a medically necessary service, that service is rendered and that claim is filed, our expectation is that claim is paid. This isn't a mandate for our MCOs to go cut services to our Sooner Care members. We want those services provided. We do have an expectation, and I guess it's a call to action to say, we need to rethink about the distribution of our spend. We need to refocus on a high value care for our member, whether that comes through primary preventative care, whether that comes from our quality initiatives, whether that comes from social determinants of health. That's why we've partnered with these organizations that are the experts in their field. So again, it's not a mandate. Our members will receive the care that they need, and the care will be reimbursed.
I have one last question. How do you activate your members beyond your providers? I've had numerous patients that diabetic hypertension, I'm sure the providers can speak to the same. We can talk to them blue in the face and then all of a sudden nothing happens after we leave the office. There is no skin in the game for a patient. Providers have the skin in this game, and only providers, period.
Okay, so remember when I said that currently under federal law, we can only pay for medically necessary services? The plans have the authority under the federal regulations for managed care to incentivize members, to have members put skin in the game, to incentivize them to do well child checks, to supply them with a car seat, which we can't do. Anything that family needs that gets them engaged in their healthcare delivery, they have the opportunity to do that. And that's one of the main reasons why we are committed to moving forward with this program, because we, as Kevin said, we are limited on what we can do to improve the healthcare in any community. And we are in Oklahoma City. These plans are going to be in counties across the state of Oklahoma. So there's going to be a local presence, and there's going to be impactful things that they can do that we can't possibly do today. So I think the more we talk about things that they have the opportunity to do, gives them, their value add list keeps getting longer and longer and longer, because we keep hearing things across, in every town hall we've had, we hear concerns from the community. And the only way that we can make this program work is by coming to the community and having the health plans understand what's going on in this county, in Poteau. So when they come into your community, they know where to go to find out how to make the most impactful impact on the members that we serve today, that they will serve for us in the future. If they don't do that, they all know me. I've been with the Healthcare Authority 15 years. I am the loudest voice and they will hear me. So that's one of the things that we do in oversight, is make sure that what we agree to do with them contractually, they agree to do in their response to the contracts, and our oversight services and function and collaboration that we have with them is massive. So I'll be happy to give you my card and we can talk about it 3 months after it goes live.
So I just wanted to add real quick on top of what Melody said. One of the specific ways that we can engage our members so that we can get over that hump and get them the care they need, how they need it, where they need it, when they need it, it's to increase the level of stability for the members. And that means addressing the social determinants of health that we hear so much about. So that's a key part of our strategy, is to, because we have these new partners with new tools available to us, because of the different rules for them compared to our agency, we can tackle those problems and free up the members, your patients, to respond to your recommendations and to your treatment plans more effectively and more reliably.
My name is Beth Heights. I'm one of the providers here in Poteau as well. I see a large population of pregnant women and children, and currently you have a program called Soon to Be Sooner that covers illegal aliens with their pregnancy. I want to know how these managed care plans are going to assume that care. With the current political administration, I see those numbers going up. And I want to know how these women are going to be taken care of. Also, to piggyback on that, I fear too that currently the delivery services are very sparse. We had to shut our own labor and delivery down. I see patients until they're about 34 weeks gestation and then transfer them. They go across the state line to Arkansas. What if our hospitals over there decide they're not going to get involved in this? And we're not going to take those Oklahoma Medicaid patients or soon to be sooner patients. I see problems. I see a lot of problems.
Thank you for those questions. So I'll start with a great question on Soon to Be Sooners. It's a program we value, and we have two, one for undocumented and one for documented women that meet certain poverty limit thresholds. Both of those will actually stay maintained as being administered by the Healthcare Authority. So those populations, just like our Advantage waiver and other waiver members, will stay under our direct service delivery model. So they won't transition. On the other one, I would say that rural hospitals closures, things that we're talking about today, these are not new to us, and they're things we deal with. You know, unfortunately, we have dealt with in the past and worked on reimbursement rates. We have individual conversations with those hospitals. I know I have direct involvement with like the psychiatric hospital folks, and I've had conversations begging, pleading, what can we do to keep you open? Because it's an access issue for our clients. And so I would imagine that the process would be very similar. It's not going to go unnoticed if we start noticing rural healthcare providers, much less hospitals, threatening, not threatening is not the right word, but just, you know, letting us know that they're not financially able to continue. We would intervene at that point and work with the plans to make sure that doesn't happen. And I would say as our out-of-state providers, we use out-of-state when we have to. We actually, our border placements, we consider in-state. So most of our out-of-state, technically Arkansas and surrounding states, we consider as an in-state provider. They accept our rates. So we would have the same conversation with them if they were to send us a letter saying, we don't want to participate anymore, we would outreach to them and see what we can do to keep them as a provider.
Hello, my name is Victor Clay. I am a home medical equipment provider in Southeast Oklahoma. We've got a couple locations there. And one of the things that, let me start off by making a statement, if you don't mind. So I understand, and Mr. Corbett, you and I have had conversations before. As many of you up there on the panel, we've had conversations concerning the reason for moving to the managed care model. And so I wanted to do a little research to check it out. The question I posed in the past is what information do we have when it relates to healthy outcomes in these other states? Can we go off of to determine that this is the right move to improve the health outcomes in the state of Oklahoma? So I did a little research and I looked on the Kaiser Foundation. I believe that's the information you guys have utilized in the past to determine that we are, and unfortunately, yes, we are 46th in the nation. But one thing I did notice is looking at that information is I looked at the top 10 states and the bottom 10 states, and in the top 10, there are, out of the top 10 states, there are 8 programs, 4 of which are partial MCO programs, and then the other 4 that are fully part of the managed care model. And I looked at the bottom 10, and there are 7 states that have a managed care model in the bottom 10. So I would just kind of wonder, that didn't really give me a very good correlation that managed care is the answer to improving health outcomes in any particular state, because they're virtually the same, top 10 versus bottom 10. But that being said, one of the things too that I can tell you that is a concern, and has to do with, I think, gentleman back here, I'm sorry, I don't remember your name, but he had talked about the rate situation. And, you know, we can talk about the effects that reimbursement rates have on businesses. I know last year in our industry, we worked very closely with the healthcare authority to establish a viable rate methodology for our industry. And I thank you guys for that. It was very successful. I really appreciate the authority in doing so. But I will tell you that concern is, as we have started to receive contracts, and to get even more specific as far as rate methodology, the one that I've received this week is 70% of the current Medicaid fee schedule. That is a concern, obviously, for my business, but more importantly, for you guys, I would think that would be a concern for the members. And what I mean by that is, in order to improve health outcomes in the state, if you are to cut your providers, in this particular case, 30% rate methodology that they currently experience, and expect them to provide the same level of care to the patients and or even contract at all, because they may not be able to they have to make some business decisions whether or not they can continue to contract at those rates. That's a very scary thing to think about, and those are going to be decisions that we're going to have to make. I also have a location down in Northeast Texas and in Paris, Texas, and managed care has been in place for quite some time down there. One of the issues that I face down in Northeast Texas is I actually am a provider for very few Medicaid recipients in the state of Texas, because I can't afford to live with the rates that the managed care organizations have provided or put in their fee schedules for home medical equipment providers down there. And so I've had to make business decisions down there, and it's very difficult to have to turn away patients, especially when I get phone calls from existing patients or from patients that are currently enrolled in one of these plans, and they want me to take care of them because their current provider that is enrolled is not able to get up to see them as frequently as they need to. For instance, taking care of oxygen patients and whatnot. So those are some concerns that I really don't want to see the state of Oklahoma to move towards, because I think that would not improve health outcomes in the state. That would potentially decrease and make those health outcomes worse.
So Victor, good to see you again. And I know we've had a lot of conversations on this. As far as your concern, it's our concern as well, because we need to have an adequate network we've talked about. That includes having the providers that we have today, as well as those that we'll need in the future. One of the things that we gave the plans the flexibility to do is not simply to follow our fee schedule or to make significant reductions, but also to have performance-based contracts that reward for performance, if you will. As you probably know, we don't do that with our current population today. I think anyone that's a provider would say that there are certain providers that have done phenomenally well and some that probably haven't. This is a way to compensate those that do extremely well and obviously compensate those for their services as well in a fee-for-service basis. So we've given the opportunity to have some flexibility, but it is one that we still have. The ultimate responsibility is an adequacy of network. If there can't be an agreement made with regards to the compensation model, it puts pressure on the adequacy, and we're going to know both. We're going to know what the contracting process is, what the agreements have been, as well as what that results in terms of the adequacy or lack thereof of a network. We will not go forward without an adequate network for our members. You're exactly right. We think about the members always. And if the network is not there, then it's not good for the member, and therefore we won't go forward at the time frame. We'll work to get that adequacy in place. It's a fatal responsibility.
The thing that I would like, excuse me, the thing I would like to ask, because Traylor mentioned it earlier on in the presentation at the beginning, I think that, or answered the question, I can't remember exactly, Traylor, but you mentioned that there was no way that you could get an adequate network, if you will, if the managed care organizations aren't reimbursing at the current fee schedule. And you said there's no way to do that when there's a 20 to 40% decrease or whatever. And in our case, we're looking at one of the four that have said we're going to give you a 30% decrease. So that is a definite concern. And one last question, and I'm sorry to keep taking so much time, but one last question is, and this is more as a taxpaying citizen than it is a provider. One of the things that back in January, there was during when the awards were mentioned at the press conference for these four insurers here, one of the questions asked by the media was, do we anticipate a reduction of staff at the healthcare authority? And Mr. Corbett, you answered the question and said, no, our roles are going to change. We're going to shift over to more oversight and regulation, if you will, to make sure that those entities are doing their jobs appropriately and effectively. So my question is, will this drive the cost of healthcare up and the burden to the citizens by maintaining the same labor cost, if you will, at the healthcare authority, while at the same time having to pay an outside, or in this case, 4 plus I believe the 3 dental, 7 different entities to administer claims? Will this drive the cost of healthcare up in our state to where we can afford it? Just out of curiosity.
No, it won't. As we've looked at our program today and what our role has been, there's a real opportunity to we say, somewhat redistribute how healthcare is delivered in the state and compensated. There is a number of things that we don't do today that we think is cost effective as well as health effective as well. So the coordination of care and the management of that is kind of where the opportunity exists. Our board, as you probably saw, you were at the board meeting in January, approved the compensation for these 4 plans and as well as dental plans. That was a portion of our already existing budget. It was not an increase in budget. And so our commitment to the legislature and our partners and the taxpayers is we'll live within that budget. It's all about managing care, and that's where our focus is in.
So once again, I'll ask one more question. I'll leave you alone, I promise. So that being said, then is that going to affect the capitation rates that these entities receive? Will it be, in order to do that, like you talked about, and maintain the same staff that we currently have, will it affect the capitation rates that are paid to the MCOs? And if it does, if it drops those rates specifically, then that's going to leave less healthcare dollars available that are taking care of members' healthcare needs, which will once again negatively affect the health outcomes in the state. I do believe I'm just kind of a common sense guy. That's just kind of the way that and I may be looking at it wrong. That's just an opinion.
Well, the way and Aaron can explain this better than I, but the way the capitation rates are established is simply on the basis of what's actuarially sound, if you will. So we've engaged experts in doing that actuarial determination. That's where the 40% that's been referenced. It's part of the actuarial report and study that was performed to establish those rates, which is subject to our federal partners' approval. So they're based on sound actuarial assumptions rather than trying to live within a certain dollar amount, if you will.
We're going to get to a few of our virtual questions real quick. When contracting with each individual source, how will we know when our client has been assigned to a particular OHCA Select provider?
So we're going to have what we call initial enrollment that'll be a process this year, and then we'll have open enrollment that'll be our steady state starting next year. The way initial enrollment this year will work is that we will have, starting July 1st, we're going to send notices out to our members that will be eligible for the SoonerSelect plans, letting them know that, hey, August 1st, you're going to have the opportunity to sign into mysoonercare.org, choose one of our 4 medical plans or one of our 3 dental plans. And then we will give them numbers to our member services desk that will be trained in all the plans and all their various value-added benefits that they offer on an individual basis. We'll also be able to talk to those members when they call us about where are their providers aligned. Are their providers aligned with Blue Cross Blue Shield or United or Humana? That way they can make a choice plan based on where their current providers are contracted or not. After that, if a member has not made a choice by September the 10th, then we will do what we call an auto assignment. It's going to be a very basic round robin, assign members to a plan until every member that is not chosen is assigned. But as Mel alluded to, that doesn't mean they're locked in. They then have 90 days. So they'll get a letter saying you've been assigned to United. They're going to manage all your care from here out. And the member says, I don't want to be with United. So they can call us or log online and then change their plan based on information known to them, such as benefit comparison guides, much as we get if you have a commercial insurance. So they'll then have that 90 days to make a change. After this year, we're going to get on a state fiscal year as far as open enrollment period. And so open enrollment next year will start in May. And then so they'll have the chance to change plans if they weren't happy with the previous plan. And from every year that on, open enrollment will happen every May.
Many of my pharmacy patients are covered by Medicaid. What will the dispensing fee be under these new PBM contracts?
Like we mentioned before, we're not abandoning what we do currently. We're just adding to that. In our contractual agreements, the dispensing fee will be the same as what we currently pay from the state.
Will the new insurance cards have a logo to determine that the plan is Oklahoma Medicaid or SoonerSelect?
The members, after they choose a plan, will have a card that identifies their carrier at that point. So if they're in a SoonerSelect plan and it's by Humana, they'll actually have a Humana card they will give their physician's office.
We have time for one last question here in person, if we have anybody that would. There will be time also to meet with our panelists individually afterwards.
Hi, I'm Tiffany Griffiths. I'm a provider here in Poteau. And I guess my question's more leans toward the quality aspect of the reporting mechanisms that you guys say you have in place. In December of 2020, the American Hospital Association published information about the increased rate of denial authorizations and prior authorizations from the managed care organizations currently. With that going, I know that, Mr. Valentine, you had spoken about you're going to be watching these things as far as quality reports are concerned, and that these managed care organizations are going to have to turn information into you. Are those can you give me some specifics as far as what quality reports and quality measures are going to be reporting to you on the patients? And are those quality reports going to be public? So the beneficiaries can look at those and review those, and the providers can look at those, and the hospitals can look at those to see where those measures are at and what the goals are. And if they're below the threshold, what the reporting, what their quality action is going to be to fix it. And then also, is there going to be any type of audit into the information that's submitted to the healthcare authority? So, because as we all know, I can give you numbers and say this is what it is, but is there any investigation that's going to say, hey, this really, kind of like y'all do with some of the charts that we submit and get payment for? Is there going to be any audits as far as these organizations are concerned with the quality measures that they're reporting?
Yeah, so I'll start with the second. You can tell me if I forget some part of that. The initial piece there is the external independent review organization as far as making sure that the data we get from the health plan is valid and is vetted. And so part of this process, there's actually a federal requirement that we have a independent review organization. It's called our external quality review organization that vets the information that comes to us on the quality side. It includes performance improvement projects, it includes encounter data, includes a number of things. So yes, there's a process to vet that information, and there may be other aspects in the offsite to that also apply to that. When it comes to the quality information, what type of quality information I heard you ask, and will it be public? Yes, it's going to be public. Transparency is a key part of quality improvement. We want that to be available to everyone because we want those numbers to move and improve when it comes to quality of care indicator data. When it comes to the denial rates, I'm not necessarily sure if that kind of information would be public, but but it is something that the organization will be watching, that OPA will be watching to make sure that if there's an excursion from what we would expect, then we need to do a deep dive and review on our UM side and utilization management side.
As I've mentioned, we do have a contract with each one of these plans, and they have multiple provisions in there, contractual provisions and requirements that will be monitoring compliance with that on a real-time basis. I mean, it's important that not only we have those provisions in place, but we understand how they're being met. In our action, our responsibility is to ensure that occurs. And if it does have an exception that's occurring, we understand the nature of that, how to fix it, and how to resolve it on a timely basis. So that's our role, and that's the organization that we're transitioning to, is to have that level of oversight. Some would call it surveillance. I call it kind of ongoing monitoring, to understand how our partners are performing, just like we do today with our own employees. We monitor performance of our employees with regards to what we expect to occur and what's actually occurring. So we will follow that same kind of logic, if you will.
So if we have a patient that feels like they're not getting the level of care or as quickly as they would like, is there a number that they need to call, or who do they complain to if this service is not working for them?
Sure. So their first stop is going to be with the managed care plan, as they would with us. They would let us know. So they're going to let the plan know first to see if their appeal system can address it quickly. If beyond there it doesn't address it to the member satisfaction, they will have opportunity to grieve with the healthcare authority through a fair hearing process, much as they would now. So we'll be available to receive those complaints as well. And if I can't, I know we're running a little behind, Melissa, but we failed to talk about kind of what our readiness process looks like and what we're doing currently and the oversight process. So I will say most of the folks sitting at the tables will let you know that I email them on a daily basis. If I see them slipping up on something, they're going to get an email from me, and I get a response probably an hour later from them making sure it got addressed. But what that looks like right now is we have 10 implementation work groups on various subject matters that we meet with the plans an hour each work group per week. Melody and I have calls with all of the CEOs of plans weekly, as well as Dr. Luce on the dental side. We have a team of about 18 people that are internal staff that are our readiness review team. So what that means is we have received volumes of policies, procedures, medical necessity criteria, everything you can imagine that we required for reporting from the plans that they're now submitting to us, that these readiness review teams are diligently reviewing to make sure it complies with the contract. Very tight timeframes for that. We're turning that around within about 3 weeks. After that, there's going to be on-site reviews from our partners. Corey, you didn't give me the pull my ass out. We'll have on-site reviews with our partners because they're all required to have physical space within Oklahoma City. So we'll be over their shoulders looking at their systems to make sure their call centers are working right. They're able to get into their systems, see our members, and run through their processes with us. After that, Victor mentioned the adequate network piece. That's something that we require weekly as far as readiness reviews, but it's also something Melody and Dr. Luce and I meet with the CEOs weekly to talk about their network, where it's at, percentage change every week, as well as their staffing plans. And so let's say that one plan that's offering you less is not ready by our drop dead date of September 1st. That plan doesn't move forward. So we have several safeguards in place to where we also have to have CMS approval of all these things. So we mentioned the actuarial rates. CMS approves the rates, they approve the contracts, and they make sure that they're actually ready as a state and as an individual plan to move forward. So if any one of those plans or as a state we're not ready September 1st, we're going to hit pause, or if we don't have federal approval, because that will give us in that month time frame to get in touch with you all as providers, to get in touch with all of our clients to say plans have changed for the meantime, and then let them know the new direction we're going. And then most likely the next viable option to press go would be January of 2022. So there's several stops along this way that we've set as safeguards and really just to give ourselves time and our members and our provider community times to pivot.
I do have one last question. So I've had several patients come to me lately, and mainly they were Blue Cross Blue Shield recipients. And they have said that they've received a letter from them stating that to get their medications filled, they have to get them filled for 3 months supply. They have to get them filled at a Walgreens pharmacy. The closest one is Fort Smith and McAllister to us. So they're going to have to, and it's not even a mail order service. So they have to go to those facilities to pick up their prescriptions. They can get them filled locally, but it's going to cost them more money and they can only get a 30-day supply. Is things like that written into the contract where, I mean, because our local pharmacies, our local business owners are losing money because of these contracts like this. It's not the only one. Blue Cross Blue Shield just happens to pop in my mind. I've had other patients that had other managed care organizations covering their stuff. They've come to me with the same thing, that they have happened to contract with Walmart. So now they're having to move their prescriptions from a locally owned pharmacy to a Walmart pharmacy. And Walmart has restrictions on providers as far as opioids are concerned on how much you can give them. So some of these businesses, I mean, how do you make sure these patients are getting what they need when these businesses have already put into place these loopholes or, I don't know, barriers for these patients to get the needs that they need?
Before I raised my hand,
Yeah.
that was exactly because we were running into that problem as well, so that was what I was gonna ask.
So I'll let Terry specifically address the pharmacy piece, but what I will say is, I'm hearing you say managed care, but I think you're referring to commercial. So there's gonna be very wide differences in a commercial plan that is offered through a Blue Cross Blue Shield and United in the commercial market and a Medicaid managed care program. So their commercial lines of business aren't monitored by the Medicaid agency. They report to the insurance department as well as their crediting entity. So it's gonna be very different. They don't have that level of oversight that we're gonna provide their line of business for specifically for Sooner Care.
And we do have items in the contract to prevent those things from happening. We have clauses in there about not steering patients, not incentivizing patients to get a less copay to go to mail or another pharmacy. So those things are written in there. And then we also have a piece in there that any marketing material such as that type of letter would have to go through us for approval first. So we're anticipating to not have that type of issue.
Thank you guys for your questions. We do have some viewers online who would like for you to introduce yourselves again. Those on the panel, they are trying to keep track of who's who, and it's a little more difficult online. So if you wouldn't mind just going down the list one more time. For those of you that still have questions, our panelists will stick around. Feel free to visit with them. Also feel free to visit with our partners who are here with us in person. Thank you guys again. Go ahead.
Melody Anthony, I'm the State Medicaid Director and the Chief Operating Officer.
Taylor Raines, Deputy State Medicaid Director.
Aaron Morris, Chief Financial Officer.
Karen Luce, Dental Director.
Terry Cothran, Pharmacy Director.
Dr. Valentine, the Chief Quality Officer. Thank you all for your time.
All right, thank you all very much for being here. We understand it takes time out of your day and we really do appreciate it. We're doing a series of these across the state, so this won't be the last time we have the opportunity to hear from your colleagues. If you have questions, as Melissa said, please provide those to us. You can send that to our website and we'll certainly answer those. We're cataloging the questions we've received from the last 2 town halls. Many of those may be questions you have as well that we didn't get a chance to address today. We'll certainly do it that way. And we do appreciate your partnership with us as part of the Sooner Care program. Like I said, we're blessed with 70,000 providers. It's very vital to our members. We're going to have 200,000 more joining us. So having us all in this together, we certainly do appreciate it. Again, thanks for your time. Thanks for joining us. Have a great day.